It's communication. So long as your patient understands and you've taken the time, then I think generally you'll probably find that if something did go untoward, there would be an understanding.
Hello, you're listening to the Dental Protection Podcast, and this is the In Dentistry series where we are looking at diagnostic errors, which are often the drivers for the cases and claims that we deal with for members. These podcasts are focusing on different clinical areas of practice and looking at some of the specific issues that arise and how these might be avoided. My name's Yvonne Shaw. I'm Deputy Dental Director and Dental Underwriting Policy Lead for Dental Protection. Now, today I'm delighted to be joined by Caroline Robbins. Caroline brings a wealth of experience as a practicing dentist, having trained initially in New Zealand and worked in Australia. She's been looking after patients in Carlo Island for over 20 years, ultimately opening her own practice, Kiwi Dental, in 2012. Now, she's also the outgoing president of the Irish Dental Association and was in fact the first non-Irish graduate to hold this role. Of interest, Caroline was recently interviewed by a national radio station in Ireland on a very specific aspect of cosmetic dentistry, and that's the issue of dental tourism and turkey teeth. No doubt this will be relevant in our chat tonight. Welcome, Caroline, and thank you for joining us today. In today's episode, we will be discussing some of the challenges that can arise in the field of cosmetic dentistry in ensuring the diagnosis and treatment plans are appropriate for that patient and how to reduce the risks of errors arising. Cosmetic dentistry is an area in which we're seeing significant growth with increasing patient demand and more dentists, including those early in their dentistry career, moving into this field of work. Now, whilst patient demand is increasing, this is coupled with concerns that have been reported relating to dental tourism, with younger patients proceeding with veneers as the quick fix for their dental smile, without perhaps fully understanding the longer-term implications. From a dental legal perspective, this introduces new risk factors, with patients in future presenting for replacement and remedial cosmetic treatment, where the prognosis of teeth may already be compromised. For those new to cosmetic dentistry, the complexity and risks of treatment may be underestimated, leading to errors in assessment and diagnosis and potential failure to achieve a desired outcome. So, by way of introduction to the topic, Caroline, is somebody who has an interest in cosmetic dentistry. I'd welcome your own kind of input as to your experiences of managing patients' cosmetic dental needs. And so my first question to you is, have you seen an increase in the demand for specific types of treatment or the need to manage pre-existing cosmetic treatment that's been undertaken elsewhere?
Thanks, Yvonne. And first of all, thank you very much for inviting me here today. I'm glad to be able to offer perhaps some insight to things that I may have seen myself in my own clinic and over the years of doing general dentistry. Interesting first question. Have I seen an increase? I would absolutely agree with that. Since COVID, I have seen an exponential increase in interest in such treatments. I was interviewed once and I called it the Zoom effect, that I noticeably, when we were in COVID and people were communicating from home on the computers, we were suddenly faced with ourselves. As in, when we normally would have a conversation, you would be speaking to somebody, they would be speaking to you, and you would probably be looking at their teeth, not your own. But when we were sitting staring at our computer screens, what were we doing? Critiquing everything that we saw. It's human nature, really, unfortunately. You could say unfortunately. So people started coming in and then very noticeably saying, oh, I don't like the look of this position of this tooth. It looked really dark when I was on the computer. Suddenly this tooth looked like it was hiding on me, or my teeth they looked really yellow, or they looked discolored, or they weren't the same shape. And there was a lot of inquiries into improving their smile. I think add on the increased presence of social media. So it's all there. So social media, Instagram, influencers, people putting stuff out, kids watching it, young adults watching it, judging themselves against it. So yes, saw an absolute huge increase in people coming in and wanting to improve their smile, for sure.
I mean, looking at the cases that we deal with at Dental Protection, cases that involve kind of cosmetic dentistry or this smile makeover can actually generate some fairly high value claims. The reason that we kind of see that is that the driver can be that if you can demonstrate that the patient was actually never suitable for treatment, or it was not appropriate to provide that treatment at the outset, then it kind of falls on the consent and the initial assessment. And the patient can then receive damages that not only reflect the immediate costs of treatment to put the problem right, but also ongoing replacement costs. So, for example, if you have a patient who is a fairly young patient when they first have treatment with veneers, they will then get funding not only to get the veneers done correctly, but also repeat replacements at 10-year intervals, and that becomes very expensive over the years. I think that's going to be something we need to look at, because we certainly know patients can be very determined that they're going to have one particular course of treatment. And that can actually bias the way that, as a clinician, you might then assess that patient, because you're already thinking, this is a patient that wants veneers. From our perspective as an indemnity provider, it's common that we then see allegations that start with the premise that the diagnosis and treatment was actually wrong for the patient at the outset. Another example is, alignment of teeth was such that it needed excessive preparation of those teeth to actually get the result that was required. And an alternative could have been just to have done some tooth alignment with orthodontics, some tooth whitening, and the patient would have been happy with that result. So I suppose a fairly long kind of preamble into my next question, which is, how do you approach that as a clinician? So what approaches do you take to ensure that you get that diagnosis correct at the outset, and that you're not solely focusing on what treatment that patient tends to see you with?
I think that I think about this a lot, and I think about, a lot when I look after my patients. And one thing is communication is key. So you really have to understand why your patient has come in to see you. And I take a long time to sit them down, and I say, why have you come here? What are you looking for? So they'll say to me probably, I want my teeth to be lovely and white and all one length. That's a very common theme at the moment, because that's what's smiling back at them in social media. So they think that this is something that's attainable for themselves. I then say to them, do you have any idea, or do you understand what that may involve to achieve this? What do you think is going to need to be done to get that? And they think, oh, I'm looking for composite bondings. And they think that it's a simple glue on of something, and, Bob's your uncle, my teeth are going to look fabulous. So it's really, really taking time and sitting down with the patient and asking them why they're there, what they don't like, what do they think will achieve, what are they looking for, what have they heard probably on social media, what the catchphrases, and it is composite bondings is the very common one at the moment. Then obviously I often say to the patient, you're going to see one thing, and I'm actually probably going to see something else, because I know that you're looking flat on, looking at yourself thinking, well, if my teeth look X, Y, and Z, they're going to look perfect. You have to look at it's really quite holistic. You have to look at everything. So from a clinical point of view, obviously, the first thing is I'm looking at the patient. I'm looking at the health of the teeth for a start, giving a gauge. I can, immediately looking at, very obviously, is obviously gum health. Are we working on soggy foundations? Have we got teeth that are very heavily filled? Or more alarmingly, am I looking at beautiful, otherwise healthy, beautiful, really white teeth that are lovely, that maybe just need a little bit of alignment? Then really taking time to look at occlusion, because often what I will immediately see, and a lot of times, is you'll see that there's actually nowhere to put a lovely composite bonding, that teeth are biting in such a way that you can't make this tooth look longer. So I will often then, when I see those things, I will take photos, and I also will actually just mock up, if I've got a bit of composite, I will actually do what they want and get them to close together so they can actually see, for example, that it's not as simple as they think. So then once we've sort of ascertained what might be doable, we have a good conversation about what is achievable, and talking about composite bondings. Very, very important that they understand that while they are, yes, they're lovely, and I do, I do them, and I do like them, but nothing replaces beautiful nature, and they're just not going to be the same over time. So they need to understand that what they're asking for, and what, lifespan and how they will look over time, and the management and care that is required. And when you do invest in these, it's not simply pop them on and disappear for the rest of their life. They do take upkeep as well. They need to be aware of, that if they haven't got a healthy foundation, then, that needs to be looked at first. So I often use the analogy that, you don't go and build a house on a dicky foundation. When you go to build a house, you make sure that you're buying a site that is good and solid to take what you want to build on it. And it is exactly the same in your mouth. Your foundation must be strong. It must be healthy. Things need to be in the correct position. It's just looking and looking and looking. It's so easy to get caught out. And I mean, I've been caught out. I mean, I can't sit here and say that I haven't. You might miss something a little close, and, and size of the edge, and suddenly something comes back and it's chipped, and you go, oh, you know what? that's my bad. I didn't, I just missed that. And that, it happens to everybody, but it's recognizing, making sure that the patient understands exactly what they're asking for, and then listening to what they're saying and really listening hard, because it's also important to say there can be red flags thrown at you with the things that they're asking for as well. And it's learning to recognize those too.
Thanks. I think one of the elements of the consent process, and it is that two-way discussion, is the one that's often missed is actually no treatment is always an option as well.
Absolutely, no treatment. I couldn't agree with you more. I often say, if you're related to me, if you're my child, if you're my sister, what would I be recommending? I'd be recommending we do nothing at all, because what you have is perfectly healthy. To achieve what you want is going to involve, overly aggressive treatment. And if in a patient that's very young, I just say less is more. Err on the side of caution. And I'm not averse and I'm not afraid to tell a patient no treatment, and then, and politely decline to undertake treatment.
I think tying into the option of no treatment, the other area that we see problems arising in relation to assessment and diagnosis is allegations that pathology was missed. So I think, we've talked a lot about the younger patients who may actually have very healthy teeth, but you will also get patients who have got very compromised teeth already, who are looking to try and make their teeth look beautiful again. So, we're talking about teeth that have been root filled, that discoloured, they may be missing or poor standard endo treatment, or it's dubious, it's not as optimal as we would have wanted. And I think, one of the issues we probably see is that, the compromised tooth might have been identified, but it's actually the records that don't really support, what assessment, what considerations were given. So as part of the diagnostic process, I'm sure you will have dealt with many patients who have attended to see you where their teeth are compromised or maybe not optimal for restoration. So what factors do you consider, and how do you approach managing those kind of patients when you've got that kind of scenario presenting?
Again, it's communication. It's communication with your patient. It is explaining it in terms and words that patients will understand. As dentists, we all fall into the old trap. We explain it away and we think, oh, that's perfect. It makes perfect sense. And I understand every bit of terminology I've just given to the patient. And I think if you walked out and got the patient back the next day and said, what did I say to you? Probably over 50% would say, actually, I don't know. So it's trying to formulate a language that is understandable, the layman's terms, but it's explaining it in everyday terminology. So with compromised teeth, it's a tricky one. But again, you need to inform patients. So obviously you need to be, before if a patient comes in and asking to replace a crown or veneers, well, you shouldn't just be looking at what you're looking at physically. You have to look what's underground. So, you need to be making sure your records and reflect every test. You need to have obviously up-to-date x-rays. You need to have done your vitality tests. You need to have done everything so you can make a diagnosis that is correct. Yes, you will talk about replacing, a crown, and then I think we've all been there, and you've taken that x-ray and you see that it's root treated, and then you go, oh, there's an area at the end of it. What do you do? And it is a bit chicken and the egg, I'll be honest with you. And I've had this conversation with an endodontist many times because, if they're a new patient especially, you don't have any back record of what this tooth looks like. So has this tooth been root treated for over 20 years and it looked like this from day one? And this is how it's looked. It's like a little dormant volcano. Or is it, something new? And it is a conundrum. So you have to be honest. You have to tell you tell your patient, this is what we've found. Ideally, we would be recommending that you need the root treatment redone, and then we can put the crown on the new tooth. And you need to document. So patients, they need information. They need it all, and then they can make an informed decision. We're all adults. I think at the end of the day, they can come to their own decisions. It needs to be documented. It needs to be recorded. There needs to be consent, but the patient has to be informed. Communication is so important. The patient has to be told of absolutely everything. My patients, I say to them, you must think I'm the most negative Nelly that you ever meet. I am like the fatalist. I couldn't argue that my patients don't fully, I would hope that they do understand limitations. They do understand what they're entering into. They do understand when they may say to me, look, I hear what you're saying. I understand that this isn't ideal, but this is what I need for the moment in time. I'm happy to, sign consent that this is what you've explained to me, and you document it because you've had that conversation. It's communication. So long as your patient understands and you've taken the time, then I think then generally you'll probably find that if something did go untoward, there would be an understanding.
I think the other area that, I mentioned right at the start was you'd obviously spoken on radio about this issue about dental tourism. And, whilst we can communicate the risks to the patient and making sure they fully understand the risks of that potential treatment, we don't know kind of what level of explanation kind of these patients are getting when they travel on holiday and literally sign up for treatment in a very short time frame. Of interest, the British Dental Association surveyed its members back in 2022, and it was quite staggering that I think at that time 86% of the dentists who surveyed said that they treated patients who travelled abroad for dental treatment and developed complications. So, I suspect dentists across the world are seeing patients who are travelling now to try and just get that quick fix that they want. We've discussed the compromised dentition, but, there is that potential now that we are going to start seeing patients who are younger with teeth that are already compromised, and that's going to make diagnosis and treatment even more challenging, more complex. I wondered, from your own practice, if you had experience of managing kind of patients who've travelled overseas for treatment, what were your thoughts in terms of how you would assess that and how do you manage those patients?
Yes, I'm certainly seeing, we do see it. I feel very sad when I see them, very young patients who just don't understand what they've gone for. They just don't understand what they think they're going out for veneers because that's how it's, that's how it's marketed. That's how it's branded. Well, they don't understand that veneers, even if we were doing a veneer, involves cutting a tooth. Then to their horror of horror, their teeth are cut down and they've had crowns. So many of them come back and they have 20 crowns, that's the standard, and frequently fused together. So now they can't floss, their hygiene regime is compromised. And it's simply they don't understand. So it's like whether you put it down to communication issues. I had a lady in recently, she had come to me after she'd heard me on the radio. She just wanted a second opinion of what she'd done. And she said, I thought I'd done my research. I was recommended. I'm just not sure what they've done. And I just, I find my mouth feels very full. My gums are bleeding. I thought I was going to get veneers. And she said, I couldn't understand what they were saying. They talk to each other in their own language. And, and all of it's happening above my head. And that sort of feeling of out of control. And I think sometimes it's that moment in time when they're there, it dawns on them. And they don't realize that once a tooth is cut, dentistry creates dentistry, and that is dentistry on it for the rest of its life. And while you may have a result now at the age of 24, when you're 34, if things have lasted well till that time, we're looking at replacing potentially, and then, 44, 50, 70. Can you honestly sit back and look at those teeth and say, what are the chances of all those teeth making it to the end? It's not 100%. And that is the crying shame. But the long-term result is overly prepared teeth, unhealthy foundations, hard teeth to clean, and a lifetime of dentistry. And it's not just the physical preparation of teeth, it's actually the emotional and mental issues that I'm seeing in patients coming in. I had one gentleman come in saying he struggled to get out of bed in the morning because the realization of what he had done, his mental health was at such risk that I was actually more worried about him from a mental health point of view. And I was more concerned about getting him to see the correct person for that side of it. The demons that it creates from the mental point of view is perhaps, I don't know whether we appreciate. I think sometimes as dentists we look at that, but there is so much more going on. It's very sad. It's very sad indeed.
It is absolutely tragic. And I don't think, we sometimes realise just how harmful that kind of adverse outcome can be and the devastating effect it has on some patients. I suppose tied into that, thinking about cosmetic treatment doesn't succeed, it sometimes is just that the patient isn't happy with the outcome. But we also see cases where the outcome might be fine, but actually then the restorations start to fail. So we see debonding, we see fractures. And I think it's quite easy as a clinician that you get into that cycle where, one veneer fails, so you just replace it and then it fails again. And we've certainly seen cases where the patient may have gone through 2 or 3 cycles and then starts to get disheartened and the teeth are devitalizing. I just wondered from your own experience, if you've seen cases like that, because I think sometimes it's going back to basics, isn't it? And before you actually replace it, finding out why things have failed. So How do you deal with those kind of patients when they're coming back and things aren't working?
It's important to realize that, as a clinician, we're only human and you're only human, and no one sets out to cause any problem. And I think we need to tell ourselves that more often, because I think sometimes, dentistry is a tough job. It's a stressful job, and we can beat ourselves up over what we perceive as failures. No one sets out to, everyone wants to have that nice result, and that's what you've set out in your journey with that patient for. And there are times when this doesn't happen, and it is disappointing, but you can't get down by it. You have to face up. I would say face up to things, and then you have to look at why. So, okay, maybe the most obvious thing is something falls off, you pop it back on. Now, if it came back a third time, you have to start looking around outside the box. What am I missing? And often probably occlusion. It could be something as simple as your bonding procedures. You need to step back, and we need not to get defensive. Sometimes it's when patients start coming at you, and obviously they're unhappy, and then sometimes that can come across in many ways. And when they're upset about things, they can be angry, they can be disappointed, they can be, and you are as well. But you need to go at it as a team. So, and it doesn't hurt to sometimes stand back and say, you know what? If you can't find an answer, that's okay. It's important to be able to just sort of stop and say, and step back and say, what have I missed here? And if you can't find what you've missed, just say, I actually am a bit stumped here myself, and I think I would like to, if you're amenable, to refer you on to a specialist who may have some more ideas or information that might, will certainly get you the result that you're looking for, and this doesn't happen again. And I'm very sorry this has happened, because sorry is a very important word, and it needs to be said sometimes, because you are sorry. And it doesn't mean that you have failed. It doesn't mean you're not a good clinician. It just means you're a decent person, and just saying sorry to somebody will often diffuse a lot of situations.
I think it's incredibly important, isn't it, that you have that ability to actually accept that sometimes you don't have the answer, and it's not a failing. It's just recognizing that.
It's recognizing limitations. It's just recognizing when you know and when you don't.
And that kind of moves on to, I suppose, my final question for our chat today is, for anybody who's starting out in the field of cosmetic dental treatment, what would your tips be as somebody who's quite built up a lot of experience in this area? So just give us your top tips in terms of how you would avoid making those errors in diagnosis and making sure that you try and reduce the risk of an adverse outcome for a patient.
Start simple. In your first few years, your learning curve is vertical. So, and one thing I think what takes time, what we don't have as new graduates and a newly qualified dentist, is understanding what works and what doesn't. Because failure and things that break and things that don't work teach you an awful lot. And knowing your limitations. If you think it's too big a job for you, then perhaps it is too big a job for you. I'm doing dentistry for 28 years. I am 50 years old, but I still would frequently, I have 2 wonderful mentors, 2 prosthodontists, that I message a lot. If I'm not sure about something, I ask. So don't be afraid to ask for advice or ask for help. Listen to what your patient's wanting and just see if you can start picking up the red flags. Dentistry, I would say, is sort of 1/10 mechanical and 9/10 the person. So it's learning and gauging your patient, gauging that patient, the expectation levels. If you feel it's not right, if you feel under pressure, if you're being put under time constraints, you need to learn to say no, because that case is definitely going to go wrong. Make sure that you just look at all the mechanics, look at the foundations, make sure you have your x-rays, know that you're not sort of doing something on a tooth that is quietly dying or is dead and you're not aware of it. Look at the occlusion, make sure that what is actually being asked is achievable, and make sure you explain it in plain English to the patient. And also make sure you give the patients all their options, that there are other options, and especially give them the option that doing nothing is actually a treatment course.
Thank you. I think that's very valuable advice, Caroline. And I'd just like to thank you personally for taking the time to join us today. The insights you've given have been just so useful, and I hope that they're really helpful for our listeners who are working in the field of cosmetic dentistry or thinking of moving into that kind of area of practice. Also like to thank our listeners today for joining us. If you are a member of Dental Protection, you want to know more about today's topic, then please look in the podcast description for further information. For those of you that are new to podcasts, you might be listening for the first time, then make sure you subscribe to the channel to make listening easier for you in future. You can access this podcast from all major apps, including Apple and Google Podcasts and Spotify. And for more information about dental protection, or if you're a member and would like a certificate for listening today, then please look for details in the description. I've been your host. I'm Dr. Yvonne Shaw. Thank you again for listening.